Great to have you on today's webinar. The webinar is part of an ongoing series of webinars being co-hosted by the Chronic Disease Prevention Alliance of Canada and the Public Health Agency of Canada's Centre for Chronic Disease Prevention. As you can see here, our title today is Modernization of the Canadian Hospitals Injury Reporting and Prevention Program, e-CHIRPP and Injury Syndromics. And this webinar is going to be reviewing the process undertaken by the Public Health Agency of Canada to modernize the CHIRPP and injury and poisoning surveillance system. So we're really thrilled to be bringing you this webinar today. My name is Bill Callery. I'm Manager of Programs and Knowledge Exchange at CDPAC, and I'm going to be moderating this webinar. Those of you who aren't familiar with CDPAC, we're a network of many of Canada's largest national healthy living NGOs and disease organizations who've really come together to work around common determinants of chronic disease and working on prevention of chronic disease. We've got our website and social media contact information at the bottom, so please feel free to visit those. So I'm really pleased to present to you our presenters for today. We've got three presenters from the Injury and Healthy Living section in the Behaviors, Environments, and Lifespan team at the Centre for Chronic Disease Prevention at the Public Health Agency. Jennifer Crane, our first presenter, is a research associate with the team, and she's worked since 2010 on national injury surveillance initiatives. And in addition to helping coordinate the Canadian Hospitals Injury Reporting and Prevention Program and its modernization, Jennifer also facilitates stakeholder engagement and analytical products. Our second presenter, Steve McFall, is a senior injury analyst with the team and has worked in injury surveillance since 1999. He has a background in biomechanics and a particular interest in sports and recreation-related concussions. And Wendy is the manager of the team, and she has a background in epidemiology and biotoxicology and has worked with Health Canada and the Public Health Agency of Canada for the past 13 years. We've also got Jenny Subaskaran, who is an epidemiologist with the team here. She's going to be helping moderate the questions and discussion at the end, so she'll be collecting your questions as they come in on the chat feature throughout the webinar, and we're going to have probably about up to 30 minutes for answering questions at the end. So I know our presenters are really pleased to be sharing the agency's work on the modernization of the Canadian Hospitals Injury Reporting and Prevention Program and Injury Syndromics, and without further ado, will hand it over to Jennifer.
Thanks very much, Bill. So again, I'm Jennifer, and thank you also to our audience for your interest in our work. And Steve, Wendy, and I are really pleased to be sharing our story of CHIRPP's modernization, which has been a team effort between the injury team, analysts and coders alike, and the Canadian Network for Public Health Intelligence since 2011. So I'll just first provide some background, rationale, and description of the features of CHIRPP and e-CHIRPP, and then Steve will take over after about 10 minutes to discuss the concept and application of Injury Syndromics. And Wendy will then present an Injury Syndromics proof of concept study involving detergent packets, and we'll also wrap up with some concluding remarks. So launched in 1990, the Canadian Hospitals Injury Reporting and Prevention Program is an emergency department-based injury and poisoning surveillance system currently operating in 11 pediatric and 6 general hospitals across Canada. And the aim of CHIRPP is to contribute to a reduction in the number and severity of injuries in Canada. So how it works is when a patient with an injury or poisoning visits the emergency room of a CHIRPP hospital, they're asked to complete a CHIRPP form, which is essentially like a questionnaire that asks about the injury event in terms of who was injured, when, where, what happened, what they were doing, if there were any products involved, and a number of other questions. So it's just a snapshot of the injury event. And this CHIRPP form is also unique from other data sources in its capture of the what happened story via a free text narrative, which allows the patient or their guardian to describe the injury event in their own words. And this allows us to discern the pre-event details of the injury that are not typically available in other national Canadian injury data sources. So in terms of the data, CHIRPP has 2.8 million records spanning 2 databases, namely the older CHIRPP database, which has the lion's share of records at 2.3 million, dating between April 1990 and March 31st, 2011. and the newer, more recent e-CHIRPP database, which contains about 500,000 records dating back to injuries sustained from April 2011 to the present day, and it's growing even as we speak. So what is this information used for? CHIRPP data provide essentially the evidence needed to invoke positive change in the health and safety of Canadians, and I've provided some examples on the slide here. So, for instance, CHIRPP data contributed to knowledge that influenced the 2004 prohibition of the manufacture, distribution, use, and sale of baby walkers in Canada. CHIRPP data also provided evidence of eye injuries being sustained from single-pronged display hooks in stores that led to many major retailers installing safer hooks. We've also influenced changes to Canadian Safety Association standards for children's play spaces and equipment, influenced change in the legislation in some jurisdictions for ATV use among youth. CHIRPP data have also influenced body checking rules in Canadian youth hockey, and of course local injury prevention and safety awareness programs and campaigns have also used CHIRPP information and statistics. And over 100 peer-reviewed papers have been published to date. And on that note, please keep your eyes open in June of this year in our agency's journal, the Health Promotion and Chronic Disease Prevention Journal. We'll be publishing a paper which essentially summarizes a lot of what we're discussing today. Okay, so the text is a little small here, but you can actually see this poster online on our website as well. But this is a 25-year timeline of some of the highlights of CHIRPP's contributions to injury prevention since 1990. There's also some highlights of other Canadian injury prevention initiatives. And so, again, I encourage you to take a look at our website just to get a closer look of some of these highlights. And here's a map of our current and past CHIRPP sites across Canada, and you can see that we have a fairly evenly distributed representation across the country. And the same information just in a list format for your reference. So these are all of our CHIRPP sites, where they are, and when they join the program. So what is e-CHIRPP and its raison d'etre? Switching gears. So the E stands for electronic, and e-CHIRPP is a password-protected, flexible, online public health intelligence platform used for many things, including data entry and analysis via the e-CHIRPP database. It also has a user collaboration portal with communication and file sharing tools. So essentially, it's like a one-stop shopping integrated online platform for data entry and monitoring, data analysis, and communicating with other members across the CHIRPP community across the country. And e-CHIRPP was built by the Public Health Agency of Canada's Canadian Network for Public Health Intelligence, also known as CINFI, and so remember that acronym, we'll be using it a lot today, in collaboration with the injury section through a very, very creative and very collaborative process. And we first launched e-CHIRPP at the Children's Hospital of Eastern Ontario here in Ottawa in the summer of 2012, and it was gradually rolled out to other CHIRPP sites across the country thereafter. So all this to say, why e-CHIRPP? Why did we do this? So we really needed more timely CHIRPP data for our stakeholders, including hospitals. And we're already seeing that e-CHIRPP is generating near real-time data given the online data entry portal. And this has allowed us to decentralize data entry and have more hands on deck at one time, doing data entry directly at the hospitals. And because data entry is now performed at the hospitals, this frees up our coders' time here in Ottawa for the more complex coding of key variables. So getting the information from the patients into the database is now a team effort between both CHIRPP people at the hospitals and coders here in Ottawa. And e-CHIRPP is also allowing us far more autonomy, far more freedom over updating our coding system as new hazards emerge in the Canadian injury landscape. And this means far less reliance on our government IT services, who are already very busy. So it's a highly, highly flexible system that enables us to make changes to the information we collect as the injury landscape changes. This is just a diagram of the many moving parts of e-CHIRPP, and I won't go through every detail, as I will show you shortly just some screenshots of e-CHIRPP itself, but essentially this shows us how the information feeds into e-CHIRPP, who's involved, and some of the tools and features that are available, which I'll describe shortly. So I encourage you to take a closer look at this diagram when you have a bit more time. So it's been almost 4 years since we've launched e-CHIRPP, and we're currently in an all-hands-on-deck phase of data entry, whereby we're entering data for several years' worth of records to catch up on a backlog that had accumulated pre-e-CHIRPP. And we're really pleased that user satisfaction is very positive. And although there was a learning curve for everyone at the beginning, because it was an entirely new system, things have been running quite smoothly, and our counterparts at SynFi continue to improve and update the system as users provide feedback. It's very flexible that way. And we're also finding that we're able to catch and correct data entry errors and any duplicate records in the data far more efficiently than before, thanks to things like integrated logic checks and other tools that are able to catch glitches early in the process. And there's also a dashboard that displays data entry metrics, so spreadsheets are no longer needed for counting and tracking records. And there's also a collaboration center that has many communication tools like discussion forums, a news board, survey tools much like SurveyMonkey, and file sharing to make connecting across this very large country that much easier. And we're also delving into Injury Syndromics for the provision of early warnings of injury events and new issues, different trends, which will be discussed shortly, first by Steve and then Wendy once I wrap up shortly. So I've just got some screenshots here of some of e-CHIRPP's features. This is a couple of screenshots of the dashboard with the data entry metrics. So on the left here, we have a pie chart, and this allows us to know which proportion of the records in the e-CHIRPP database are completely coded and entered in the green versus which proportion of the records in the database are data entered but still need some coding performed. And as time goes on, this pie chart is getting more and more green, which shows we're getting closer and closer to real time. And on the right, this is just an example of how we can track the number of records coming into the system each month by each hospital. Now we have here some data analysis tool screenshots as well. So on the left, this is just a screenshot of a query builder tool. Essentially allows us to go into the online system and pull data directly out of the system on the fly, rather than having to export it into statistical software. It's just, it's a great tool because hospitals also can access their own data without having to rely on us to do so. On the right, this is just a chart, so you can also create on-the-fly charts directly in e-CHIRPP for some high-level statistics such as external cause. So again, a great tool for some high-level snapshots of the injury landscape. We also have a collaboration center within the integrated e-CHIRPP system. So there's collaboration tools like the discussion board here on the left. Any number of discussion forums can be created so we can have online conversations. One of my favorite things, because it eliminates a lot of the reply all emails that can clog the system. And then on the right here, I took a screenshot of the Documents Manager. This is for online file storage and file sharing. So the sites, CHIRPP sites can go in and access the meeting minutes, reports, anything that we decide to share within the CHIRPP community. And there's another tool that I really like. It's called a ping. I call it a quick poll. It's basically a one-question survey that we can use to poll the CHIRPP community on whatever we'd like to ask, and we can actually poll people who are outside of the CHIRPP community as well. So this is really handy for getting quick responses to quick questions. And finally, there's also some survey tools and forms tools within the system, so we can create a new form for perhaps a spin-off study or a new survey as well. So that concludes my portion of the presentation. I'm going to turn it over now to Steve, who's going to be talking about Injury Syndromics. Thanks very much, everyone.
Thanks, Jennifer, and thanks, everyone, for your interest in e-CHIRPP. Some of the changes that Jennifer was just been describing have allowed us to enhance the timeliness of e-CHIRPP. To start off, I'm going to show you two figures depicting the timeliness of the old CHIRPP system compared to the new CHIRPP system. This first figure shows the time lag, or the delay, of the old CHIRPP system for the period of 2008 to 2012. The delay is calculated by subtracting the injury date from the record creation date. So, of course, the goal here is to reduce this to as close to zero as possible. And we can see that for the most part in old CHIRPP, there was a 1 to 2 year delay in gaining electronic access to a record. Now, as of January this year, we've shifted the lag significantly into the 0 to 3 month zone. So this increase in timeliness has allowed us to begin testing the implementation of early warning, rare event, and watch list rules, which we are calling Injury Syndromics. So before we talk about Injury Syndromics specifically, let's take a look at a general definition of syndromic surveillance. So according to the UK Health Protection Agency, syndromic surveillance is the real-time or near real-time collection, analysis, interpretation, and dissemination of health-related data to enable the early identification of the impacts or the absence of impact of potential or veterinary public health threats which require effective public health action. So traditionally, syndromic surveillance has mainly been associated with infectious disease or bioterrorism. For example, patients with early-stage anthrax infection may develop flu-like symptoms and might visit primary care physicians, emergency departments, or purchase over-the-counter medications. In this scenario, the infection has already occurred, and the syndromic surveillance seeks to detect an early signal of this occurrence. So applying the syndromics idea to injury is somewhat different temporally in that there will be little or no latency. The goal of Injury Syndromics then is to detect injuries, injury patterns, or hazardous products as early as possible so that effective action or further investigation may be taken. As a first step, we set out to develop alerts for various types of pre-programmed rules. The rules fall into different categories, which I will review with examples in the upcoming slides. So the alerts were based on the historical limits method. So an 11-year historical data set was chosen for most of the analyses. The various rules were applied to the historical set to establish a baseline and set a threshold. So we used old CHIRPP between 2000 and 2010, which contains approximately 1.3 million records, as the historical data set. Some of the early years' quality issues had been resolved by then, and this represented a stable and well-coded data set. As a comparison, for some analysis, we also used a 5-year prior data set. For rules involving very rare events, simple counts were used as the alert. For example, if an event has not been seen for 10 years and in 2015 one case is identified, that is a significant alert for follow-up. In scenarios with larger frequencies, counts were normalized. That is, they were converted to proportions using various internal denominators, and the average weekly normalized counts plus 2 standard deviations were set as thresholds. At this point, we were looking at alerts that are triggered by exceeding a threshold. In some scenarios, though, such as trying to detect the effect of an intervention, the average minus 1 or 2 standard deviations may also be useful. So these same calculations are done automatically daily as new cases are entered into the e-CHIRPP system and compared to the historical baseline data. If in a given week a rare event occurs or a threshold is exceeded, SYN5 will send notification and we can investigate. Weekly analysis was chosen as many injuries or poisonings have a seasonality associated with them. Be mindful that this is in the testing phase, so there's still a 0 to 3 month delay. So we are showing results retrospectively as what we would ultimately want to see as we approach real-time weekly reporting. At the end of the webinar, Wendy will review some of the other techniques that we are exploring. So to give you a sense of the range of injury scenarios we are covering, I'll be showing you all of the rules we are currently implementing along with baseline expected counts. Due to time constraints, however, I'll only be able to show actual results on current e-CHIRPP data for select rules. Some injuries, which we're calling highly mitigated, have effectively been eliminated with various interventions, and their occurrence is expected to be rare. I will give 3 examples here from minor hockey involving 5 to 17-year-olds. So referring to the first bullet, the rule that we wrote is specifically to find eyeball or globe injuries from a hockey stick in minor organized hockey. The full visor should prevent all injuries from stick impacts, and cages are designed so that the butt end of a regulation hockey stick will not enter the opening. So just as an example here, in red is the exact structure of the programmed rule to show the range of available variables within the e-CHIRPP coding system. The SPAR variable has 145 codes for various sports and recreational activities arranged into 25 groups. The org SPAR variable indicates whether the activity was organized or informal. We can look for the age in months, in this case between 60 and 215 months, to cover minor hockey. CHIRPP also allows the recording of up to 3 injuries by body part and nature. In this case, we're looking for globe injuries in any of the 3 injury fields. And finally, e-CHIRPP factor codes allow the direct cause to be identified as the hockey stick. So CHIRPP historical data show an expected frequency of about 1 case every 2 years, but this will include false positives. Referring to the second bullet, we relax the rule slightly and look for the same cases, but with a different cause of something other than the hockey stick. Historically, we find 1 case per year, also including false positives. Finally, in looking at the third bullet related to skull fractures, while helmets cannot fully prevent concussions, current standards make them very effective at preventing skull fractures and other focal head injuries. Indeed, no cases were found in the historical data set. So these are the results of these rules run on the more recent e-CHIRPP data. So we combined between 2012 and 2015. So from these 3 rules, we did find 7 cases, but only in 2012 and 13. There were none found in 2014 and 15. So both of the eye injuries that were caused by the stick were false positives. The helmet and or the facial protection was not engaged. In one case, it was during the warm-up, and the helmet was not being worn. And the other case was likely a miscoded case as being organized when it wasn't. In the historical data set, other types of false positives included the helmet coming off in a fight or the player taking it off while on the bench. We could refine the rule by programming out these types of false positives, but it would have to be done using all the different variations of text strings, and since there are so few cases, it's easier to just manually review them. The 3 cases involving a direct cause other than the hockey stick were related to ice projectiles or the patient's own or another player's helmet. Interestingly, the 2 cases involving skull fractures were both involved with puck strike in the temporal region and appeared to be true cases, but no further information was available. We would refer these cases to the product safety group at Health Canada. So these are more examples of other rare event rules and the expected frequencies based on historical data. First, falls through spindles and guards on stairways. These cases are expected to be rare, as Canadian building codes require that spindle or guard separation to be such that a spherical object with a diameter of 100 millimeters will not pass through. Based on anthropometric tables, virtually no child 1 year or older can completely pass through a 100 millimeter opening. Well, where cases are identified, they are likely to be due to wider spacing of non-compliant structures, either old or homemade, broken spindles, or very small children. In the historical data set, 2 cases per year were identified, but not enough information was available to determine whether or not they were true positives. Now, baby walkers have been prohibited in Canada since April 7, 2004. There are still injuries related to baby walkers since the product has not yet completely left the market. They are sold or handed down through the second-hand marketplace, and in some cases, acquired through illegal sales. Between 2000 and 2010, there were 610 cases identified, of which 31.4% occurred after 2004. The count has steadily been decreasing at about 13% per year, with 9 cases recorded in 2010. Since it is a prohibited product and has been decreasing in frequency, the expected count is 0. Finally here, yo-yo water bottles are a soft plastic bottle filled with water attached to a plastic stretchable cord with a finger loop at the end. The child swings the ball overhead, and in some cases the stretch cord can make several rotations around their neck, posing a strangulation hazard. The product has been prohibited in Canada since October 2003, so incidents are expected to be very rare. In Old CHIRPP, between 2000 and 2010, 2 cases, non-asphyxiation related, were identified, both occurring in 2003. The next rule involves a potentially deadly activity played by children and youth, the so-called choking game. It's typically played by those in the 10 to 19-year-old range, although some cases have occurred with younger children. So the activity involves depriving the brain of oxygen to induce a euphoric effect, often called a drug-free high. The 2 mechanisms are typically used: strangulation or hyperventilation and breath holding. The game can turn deadly if the individual is physiologically susceptible or if the pressure is not released quickly enough after unconsciousness, which usually happens when the child plays the game alone. e-CHIRPP will miss most of these cases that result in death. However, cases involving secondary injuries due to falls after losing consciousness will be captured. Since these injuries could be of any nature and not just asphyxia, a pure text search is required to find all records. There are a significant number of street or slang terms used to describe this activity, which I will show on the next slide. The historical CHIRPP data shows an average of 5 true cases per year. So this is the text search of the current list of words that we have. So there are over 80 currently in the list, and it does grow, and new terms are introduced at certain points. Because some of the terms could appear in other non-relevant records, this search produces about 5 times the number of false positives as true positives. So some work is being done to refine the rule, but the number of cases is still small enough to be reviewed manually. So these are some of the results just with the latest year we have available is 2015. So similar to the historical average, 4 cases were identified, all involving head injury sustained from a fall after losing consciousness. Okay, a few more rules. Here are some further examples and with their baseline counts. So first, infant drownings or near drownings. These are relatively rare, and the circumstances under which they occur are usually less variable than for older age groups. The main areas are bathtubs, buckets, and sinks. Historical data is showing about 6 cases per year, 4 of which occurred in the bathtub. Cases related to bath seats occur at a frequency of 1 event every 2 years. ATVs, snowmobiles. Due to a lack of regulation in some jurisdictions, many children operate off-road vehicles. A lack of knowledge, physical size, strength, and cognitive and motor skills make off-road vehicles especially dangerous for children and youth. The minimum age recommended to operate an ATV is 16, but many youth in the pre-licensing age of 11 to 15 still drive these machines, and some even younger. Young children as passengers on these vehicles is also potentially hazardous. Historically, 284 cases, an average of 26 per year, where the operator of an ATV or snowmobile was less than 10 or a passenger was less than 6 have been identified. The next example is falls from windows, which are potentially fatal. In old CHIRPP, historical CHIRPP, there were 488 cases of falls from windows among children under 10 years of age. This equates to about 1 case per week. This rule is best implemented using a text string search. But there can be many false positives, such as falling from the window, back into the house, onto the floor, or falling into a window. We are currently working on refining a rule to remove irrelevant cases. Second to last one is serious injuries requiring admission to hospital to children caused by toys. This may identify new products or new hazards associated with specific toys. In the historical set, there were 248 cases, or 23 per year, involving children under 10 years of age requiring admission to hospital for an injury where the toy was the direct cause. Of those cases, almost half were foreign body ingestions or aspirations, suggesting small parts, break-offs, or the toy was age inappropriate. The last example is another group that we worked with works mostly in the intentional injuries and suicide. So we people look, CHIRPP captures those cases as well. So we're developing some rules to look at those. Specifically here, self-inflicted injuries among females, both with and without suicidal intent, are of growing concern. Of further interest is the existence of clusters of self-inflicted injuries at a specific hospital on a specific day. Historically, there are about 5,000 cases of girls 10 to 19 years of age presenting to an emergency department for self-inflicted injuries, with the hospital average ranging from 0 to 22 cases per week. By date of injury, the range is 0 to 4 per day in any given hospital. Still, it's quite low, but the expectant frequency would say it's close to 0, but it will be a rare event for this specific rule, but we are tracking it weekly. Now, this figure depicts the results. It's sort of a relaxed version of that previous rule, just looking here at the self-inflicted lacerations among females 10 to 19 years of age. So the blue bars are the normalized counts. That is, they're the count as a percentage of all intentional cases in that week among females 10 to 19 years of age. The red line shows the CHIRPP historical average plus 2 standard deviations by week. The alerts were triggered in 9 of the weeks. So we're also tracking specific natures of injury under certain qualifications. So I'll show 2 examples of this next. Traumatic amputations and traumatic brain injuries in organized sports. Traumatic amputations are classified as either distal, which involves fingers or toes only, or proximal, which is all other body parts. These injuries are very serious and may involve consumer products. Distal amputations are the most frequent. Between 2000 and 2010, in the historical data set, there were 2,310 traumatic amputations. Of these, about 91% were fingers, 5.1% were toes. Of the finger amputations, 30% were caused by doors, and about 22% by power tools and industrial machines. Of the toe amputations, about 42% were caused by lawnmowers. Thus, although distal amputations are not rare, it's important to review these cases for their less frequent direct causes, that is, excluding those just mentioned. Proximal amputations are quite rare, less than 0.1% of all injuries. Due to severity, though, all proximal cases will be reviewed. So the logic of the rule is shown in red. Distal amputations with direct causes other than doors, power tools, and lawnmowers, and all proximal cases will trigger an alert. I'll show you some results of that in a moment. And the second example I'll have is concussions in sports and recreation. It's an increasingly important research area. We looked at traumatic brain injuries in organized sports and recreation. I will show the results using 2 different data sets for historical limits. This figure depicts the results of traumatic amputations in e-CHIRPP for 2015. Note the double y-axis. This is just to show the overall pattern, though, so we don't have the common direct causes removed yet. The blue bars are the distal amputations and the red bars proximal. The black line shows all amputations normalized per 10,000 e-CHIRPP cases in the same week. The green line shows the alert limits by week, which are normalized averages plus 2 standard deviations above that average. This figure shows some of the work we've been doing around the sports-related concussion. The blue bars are the number of traumatic brain injuries expressed as a percentage of all sports and recreation injuries in that week. We are testing differences between 2 types of historical data sets. First, in red is one we have been using in previous examples. Actually, here we have 1 extra year between 2000 and 2011. Normalized average plus 2 standard deviations. The black line shows an alternative version, which is a 5-year prior normalized average plus 2 standard deviations. So as each year is analyzed, the averaging window for the baseline moves up by 1 year. Of note in this figure is that less alerts would be generated using the 5-year prior data set. In the case of traumatic brain injuries, the difference may reflect more recent trend of increased reporting of concussions. Thus, if a trend is occurring in the gap between the historical data set endpoint and the current year of analysis, it is probably more appropriate to use the 5-year prior data set to set the alerts. We continue to analyze this data set, and we'll break it down by sport, age, and sex as well. A few more examples of natures of injury that we're looking at, along with the expected frequencies. Injuries to internal organs are expected in high-energy mechanisms such as motor vehicle crashes, motorized boats, alpine sports. But injuries due to lower energy mechanisms such as handlebar injuries, stair falls are less frequent. but important to identify as they may involve novel mechanisms or child abuse. The historical data set shows about 3,000 injuries to internal organs, about 275 per year. Of these, about 21% were motor vehicle related, 24% were sports and recreational related, and about 6% were associated with bicycling, including handlebars. The second injury that we track on this slide is intracranial injuries. They're a subset of the traumatic brain injuries and are the most serious of the brain injuries recorded in CHIRPP. Whereas minor closed head injuries and concussions are functional injuries, the intracranial injuries are structural. Historically, intracranial injuries account for about 3% of all brain injuries. CHIRPP captures about 450 cases per year, or about 9 per week, but there is some indication that this proportion is increasing. Spinal fractures can be superficial, such as a chipped spinal process, or very serious, for example, cervical fracture with cord involvement. In CHIRPP, between 2000 and 2010, there were total of 4,158 spinal fractures, and of these, about 3%, or 11 cases per year, involved the spinal cord. Second to last is asphyxia and other threats to breathing. Many cases of unintentional asphyxia will involve consumer products. Cases include hanging and strangulation in bed, or related to pillows, linens, clothing, blind cords, power windows, vending machine tip-overs, and garage doors. There will also be cases of being trapped in airless environments, including fridges and snow forts. In historical CHIRPP, there are a total of about 1,400 cases of unintentional asphyxia. Of these, about 17.8%, or about 1 case every 2 weeks, were admitted to hospital, including 22 deaths. And finally, fatalities. We often say in our the limitations of CHIRPP is that we don't catch fatalities, and that is true. They're highly underrepresented in the CHIRPP database. Many victims die at the scene or are not transported to the hospital. So CHIRPP only captures fatalities for victims who are dead on arrival or who died during treatment in the emergency department. CHIRPP's capturing an average of about 44 deaths per year, but it's still important to review them since they are associated with the most serious mechanisms presenting to emergency departments and may reveal important preventive information or new mechanisms or products. Okay, a few more now. These types are specific substances, looking at poisonings mainly, or scalding. So alcohol is a contributing factor in many different injury scenarios. Alcohol poisoning in particular can be a problem among youth. In historical CHIRPP, the average proportion of alcohol poisonings relative to all poisonings was 14.4%, but the range was between 10 and 21% depending on the week. Tap water scalds. Young children and older people are particularly vulnerable to tap water scalding, and is a mechanism in both unintentional and child abuse scenarios. In some Canadian provinces, building codes have been amended. For example, as of September 1st, 2004, the Ontario Building Code requires that hot water at household taps be no hotter than 49 degrees Celsius. The code change applies to new construction and substantial changes to existing plumbing, such as replacement of water heaters or hot water faucets. In CHIRPP, there has been a proportionate decrease in the number of these cases in recent years. Historically, the average proportion of tap water scalds relative to all burns was 2.6%, but the range was between 0.7 and 6.6%, depending on the week. Finally, poisoning accounts for a significant proportion of CHIRPP cases and is an issue for both unintentional and intentional scenarios. In particular, acetaminophen poisoning, which can cause liver failure, has gained attention recently. In old CHIRPP, the average proportion of acetaminophen poisonings to all poisonings was 14.7%, with the range, depending on the week, between 10 and 0.2 and 21.2%. So this is just an example of applying the rules to the 2015 e-CHIRPP data. Blue bars are the normalized averages of acetaminophen poisonings by week, and the red line is the CHIRPP historical normalized average plus 2 standard deviation threshold. And as we can see, at this point, no alerts were triggered. Okay, so as a final demonstration of injury syndromics, I will show some examples of annual trends associated with various products that we have been tracking either recently or since actually from the start of CHIRPP in 1990. So the first three, backyard trampolines, magnets, and button battery ingestions, and bicycle handlebars, we've been tracking these since the beginning, and I will show the results of those in a moment. Just looking at the final three bullets, more recent products that we've started to look at. The first one being hoverboards, actually called self-balancing scooters. They're a recent addition to our watch list. They seem to be a popular gift item this past Christmas, and a number of reports of fires associated with the hoverboards have emerged. So far in e-CHIRPP, in 2015-16, there have been 10 cases identified. None of them were related to fires, and 8 of the 10 cases were falls. E-cigarettes is another fairly recent addition to the watch list. They're a fairly new product on the market. A recent report indicated there are currently 466 brands with over 7,000 unique flavors, and internet sales are significant. There have been reports of poisonings and burns. In e-CHIRPP, 7 cases have been identified, 1 in 2014 and 6 in 2015, all related to consumption of the e-cigarette fluid. And finally, the detergent pods, also a relatively recent addition to the watch list, and Wendy will detail that work in the next section. So just to take a final look at those 3 products that we've been tracking for a number of years, the first one being backyard trampolines. So this will exclude trampolines in gymnasiums or gymnastics clubs or some of the new trampoline parks that are popping up. So this is strictly backyard trampolines, and they continue to increase proportionately in CHIRPP. So we're looking at this graph. The red line is the count normalized to the total number of CHIRPP cases in the given year. We are currently doing some analyses testing whether we can detect changes in the injury patterns over time as different trampoline models have been introduced to market. Magnet and button battery ingestions, they're potentially very serious injuries among young children. Button batteries can burn tissue, and magnets swallowed in pairs or with a piece of metal or with a button battery can close off a loop of intestine and cause tissue damage. The proportion of cases was consistent in the 90s, but there's an inflection point starting around 2001, 2002, where they both began to increase, presumably due to increased exposure from toys and electronics. And the final slide, bicycle handlebars. These injuries have been described in the medical literature as far back as the 60s. The most serious type involves the child falling on the uncapped end of a handlebar and sustaining an internal organ injury, which often is delayed in being diagnosed. We continue to see cases in CHIRPP, still increasing. The red line in this figure is a 5-point central moving average. We sometimes use this method or occasionally a 3 or a 7-point to smooth out the noisy data and visualize the trend a little better. And now, over to Wendy.
Thanks, Steve. So to sum that up, we have a lot of information that we capture through CHIRPP, and it's through the great works at our hospitals and the team here in SINFI to be able to collect it in real time, but the detail that they give us is the reason that we can look at all of these different aspects and different injury types. So now I'm going to be talking about injury syndromics, the proof or the proven concept using detergent packets or detergent pods. So Steve provided you the definitions for syndromic surveillance. That's on the left-hand side. We wanted to make, in order to compare it, to look at e-CHIRPP data. So we are very close to near real-time data. Our data facilitates early identification of risk factors, new injury trends, or hazards. There's opportunities. There's lots of opportunities for action, which I'll speak to later. And there's little or no latency, not only between the risk and the event or episode, but also in the treatment that is sought or that's received relatively quickly after the injury event. So a lot of this information we can capture very close to near real time, not only the risk, but the event or outcome information. So talking about detergent packets, previously they were widely available in Europe before coming to the United States, and in Canada it was introduced in end of 2011 or 2012. We received reports of eye injuries among children, and attached is the pH balance or the toxicity in the detergent packets is higher in Europe than it is in Canada or US, but it's still something to that we looked at to consider. So one of our colleagues had looked at this, presented this information, and they did an extract of our e-CHIRPP data in March 2014. Primarily, we're talking about those laundry detergent packets, not the ones that you're putting into your dishwasher. In 2011, we identified our first case. In 2012, there was 19 cases, 2013, 31 cases. At the time of this analysis in 2014, there were only 2 cases, and assuming linearity, we used methods to project an estimated amount at the end of 2014 to 46 cases. Characteristics, more males than females were being injured. The nature of injury, poisoning and toxic effects were the highest. The nature or the body part, eye injuries, and primarily patients under 5, kids that are under 5 years, most of them under 3, and all of these, or 80% of them, occurred at the patient's own home, and the rest mostly at other homes. So this is just a graphical representation of the information that I presented from 2011 to 2014. We had 2 identified cases in 2014, and assuming linearity, we projected 46 cases. So just this past month for this webinar, we did another extract. So knowing that at the time that we did it in 2014, some hospitals were still collecting information and data was still being entered. So as of today, 2011, 12, and 13 cases or hospitals have completely entered all of their information. 2014 and 15 are still incoming from select hospitals. In order to get to the near real-time projection, we hope that the data entered for 2014-15 will happen all of this fiscal year, so the closer we get to actual real-time. So comparing the 2016 extract to the 2014, you'll see we have additional cases in 2012, additional cases in 2013. Our 2014, though we projected 46 cases, at the moment we have 55 cases. In 2015, we had 63 cases. And in 2016, though we have 2 cases so far, we project, again, assuming linearity, 86 cases for injuries and poisonings related to detergent packets. Again, similar characteristics, 55% are males, the majority of poisoning or toxic effects. Eye injuries, that includes foreign bodies or pieces of the detergent pods in the eye. The children, again, 92% under the age of 5 and mostly occurring in their own home. So as we receive 2014, 2015 completed cases, and 2016, we'll be updating this and sending it to Consumer Products and Health Canada. We've also worked with a number of partners. The Canadian Pediatric Surveillance Program, which is a survey to Canadian Pediatric Society, and it was a one-time survey of Canadian pediatricians regarding injuries and poisonings related to detergent packets that they have seen. And so this is on the CPSP highlights for the results of this work if you are interested. The detergent packets, cleaning chemicals, the injuries or exposure can be severe, particularly if it comes into contact with the eye. The purpose or the design of the packets, it does what it was intended to do. They clean your clothes. However, one of the largest unintended consequences are related to the packaging. Because of the bright packaging of these pods, young children are attracted to them. They can be easily confused with candies or other food products. If they're not stored safely and the child can easily access them within the home, they can be confused. They put them in their mouth, they play with them, they rub them in their eye. So we're working with injury prevention partners and Health Canada to be able to report on the injuries that we're seeing through some of our data sources. Similarly, Steve was presenting button batteries and magnets. They are also small, can be easily ingested, and also similarly, young children cannot distinguish the hazard from, let's say, a toy or another small object. Syndromic surveillance can help identify these emerging hazards. Some of our collaborative work, we're working with Health Canada Consumer Product Safety, the Canadian Network for Public Health Intelligence, our CHIRPP sites, the Canadian Pediatric Society, potentially or hopefully the Poison Control Centers. We work with our national local injury prevention networks, researchers, and academia. So what are we going to do with this information? We're looking at mechanisms for identifying emerging causes of cases where there's no baseline data. We're looking at media, social media, national and international collaborations. Similar to the hoverboards or even looking at the detergent packets, things for products are not necessarily coming to Canada first. They're being seen in other countries. So we can use this information through collaborations to set up a watch list or alert or looking at the information as it comes in. We're testing different alert types and aberration detections and prediction modeling. We're text mining and analyses, not only our CHIRPP data, other data, complementary data sources we have, and that includes social media. We're looking at auto-coding some of the information we're coming in, and we're also working to develop a mobile-friendly CHIRPP form so that patients or caregivers can actually be able to respond to the front part of their injury form on how the event occurred online on their own smartphone. We're selectively expanding CHIRPP sites, working with the North, select adult sites, and also Saskatchewan, and so that's exciting for us. And we're also looking at working with our partners and technology to improve the dissemination of timely information, particularly to those who need to know, not only to be aware of them, but also with the intent goal to be able to prevent those injuries from occurring and to reduce the number of injuries that we're seeing. So I'd like to acknowledge for the development of the Injury Syndromics and the e-CHIRPP, Dr. Shamir Mooki and his team at the Canadian Network for Public Health Intelligence. Our participating CHIRPP sites, also our injury prevention partners, local and national, as well as our analytical and coding staff here. For this particular presentation, I'd like to thank all of you for participating and listening. I hope you found it interesting. We'd be happy to answer any questions that you have. I'd also like to thank CDPAC and our organizers here for allowing us this opportunity. So thank you very much.
Thanks very much, Jennifer and Stephen and Wendy, for that presentation. It was really fascinating, especially seeing some of those examples. I'm sure people found that really interesting. And I know we've got a number of questions that have come in and probably will continue to come in. So we've got about just under 30 minutes now to answer questions. And I think at this point, I'm going to hand it over to your colleague Janine Sabaskaran to moderate the questions and discussion period.
Hello, everyone. This is Janine. I will be moderating the questions and answers. The first question here is, are there data on psychological injury as well and other types of injuries?
Psychological injuries, I think for the most part we're capturing the physical injuries. It may be related, some of the intentional cases that we're getting may have that component. But I'm not sure how well those would be captured within our current system in terms of natures of injury.
Okay, thank you. The second question is, does CHIRPP include work-related disability data?
It includes occupational injuries, so there's a variable that flags whether the injury was related to working for pay or not. But we don't have any further disability. We're capturing it at emergency department window, so it's an injury that occurs when they get to an emerge. We're capturing that, but we're not. We don't have follow-up information on disability.
Okay. The third question, the presenter mentioned uses of codes, for example, sports injury codes to isolate injury types. What coding method is used to capture the injury type information by various hospitals that participate in the database? For example, injury that occurred from a sport versus a consumer product.
Well, CHIRPP, hopefully I'm answering the question properly. CHIRPP has goes beyond ICD-10 coding, if you're familiar with that, which is fairly rolled up. We do have ICD coding in CHIRPP, but we have more detailed information. So each variable allows us to isolate. We have codes for 145 types of different sports and recreation activities. And then with that, we can cross-tabulate it against the various mechanisms or the natures of injury.
Okay. The next question is regarding acetaminophen overdose. Was that in children under 18 or all Canadians? Also, was it intentional or unintentional for the 14% that was mentioned on slide 38?
Those were mainly, we looked at all ages in the CHIRPP database. However, it is predominantly pediatric emergency department, so it was mostly children. We could do a breakout of that slide by age. So we had actually quite a few, about 3 or 4 times the amount of graphs that we've shown here. So we have quite a bit of extra information. So we were only able to put summaries up. I'm sorry, the second part of that question was?
Was it intentional or unintentional for the 14% that was mentioned?
Those were unintentional. Okay. We separated them out.
The next question is, for product-related injury, is it possible to compare to sales in Canada? For example, injury proportionate to the amount that is available or increasing despite the amount that is available on the market. This could also apply to e-cigarettes, trampolines, or hoverboards.
I mean, that's one of the things, one of the issues here is that, this is numerator data. We don't have rates, so that's why we normalize the data. So we're looking at sort of within the CHIRPP system relative speaking, we don't have overall denominators. And sales of various products is something that we've always wanted to get a hold of, but it's not that easy to get a hold of. We talked to our partners in Product Safety and Health Canada about that, looking to get some general information like that, but it's at this point we haven't been very successful.
All right. The next question is, would it be possible to include a field that could be used to identify First Nations, Inuit, and Métis children to e-CHIRPP?
We used to have a variable, I think it was ethnicity, that we had, but we found that it was very highly skewed, so the numbers were so small. I can't remember the distribution, but the numbers were very small, and it wasn't filled out that well. The proxy was the language most spoken at home as well. It wasn't direct question; it was a proxy. So we found that we didn't use it that often, so we actually had dropped that variable. But it may be something that will come up in the future if we're looking at the ad hoc.
And the final question is, can CHIRPP be used for surveillance of opioid-related unintentional harm?
Yes, we have done some work with opioids as well. We've done it with text searches as well, looking for we've worked with another group in Health Canada looking at text searches within CHIRPP for the various names of drugs and either brand names or street names. We've done a little bit of work in that area as well.
We just got one more question. Are you looking at expanding e-CHIRPP to more hospitals across Canada?
We are looking at expanding e-CHIRPP, but we're going to be selectively expanding because we're also using complementary data sources and some data linkage, particularly between perhaps CHIRPP, NACRS, which is the National Ambulatory Care Reporting System at CIHI, as well as the discharge abstract or hospitalization. we're looking at the north at the moment, Saskatchewan select adult sites, and we'll have to look at it as time permits and where there is a need to be able to capture different type of injuries, perhaps rural versus urban, than we might not already capture. So hopefully that answers your question.
And that concludes all the questions that we have received. Thank you.
Thanks, Janini. It's Bill at CDPAC, and I don't have any questions coming in by email, but we certainly have a few more minutes if people have some burning questions. People online have some burning questions that they want answered. But I have a question myself, and I don't know if you addressed this in your presentations, but it's just really interesting looking at some of the graphs in terms of increases in injuries from things like bicycle handlebars and these magnet and button batteries and trampoline injuries, and even with the detergent packets. And I'm wondering sort of like how do these, well, maybe for the first part of my question is do you have any insights in why injuries like that are increasing, and then what happens as a next step as a result of some of this data?
Well, for the trampolines, it's and again, it goes back to that previous question about sales data. We don't have a denominator here, so the increase is partly due to the just being more of them being sold, and there's a higher exposure. There's more of them in backyards, so we still have that missing denominator. But that's part of it. I mean, it's still an increasing problem, even if we don't have the denominators. They're happening because there's more trampolines out there. Bicycle handlebars is another area. I mean, I've been looking at that for a number of years, and it seems to be persistent. And I've talked to people in other countries and seeing the same thing. It's something that's always there. It hasn't gone down. Some years it leveled out a little bit, but and with different types of bicycles, there's different types of handlebar injuries that have happened. There have been a few cases where it wasn't the handlebar, but it was the brake caliper. There's been some penetration injuries from brake calipers and such. So sometimes new sort of slightly different hazards show up with new types of bikes.
We have just received another question. Why are certain injuries increasing? Do you receive injury case information related to pesticide use?
They would go on. There would be under poisonings, if it was a poisoning related to that. That we do have factor codes that will allow us to group them up in. I'm not sure the level of detail that we can get at for pesticides, but there is a category of that would be placed in as a direct cause of a poisoning.
We've also received another question. Some different alert types were mentioned. I'm wondering if there is consideration of using other predictive modeling software techniques, using SPSS Modeler, for example.
Yes, and Wendy had mentioned that at the end of the presentation. Sort of as a first step, the historical limits is kind of a logical starting place for this type of analysis, just to get a sense of what our data looks like and what the signals will look like. And then the idea is to kind of progressively do more complex types of analyses. And one of the limitations of the historical limits method in the literature, although this may not be as applicable to injury as it is to infectious disease, but that the historical data set is influenced by large-scale epidemics of the past. And also, as we saw in that traumatic brain injury example, recent trends can affect baseline levels. So the next step there was looking at this immediately prior 5-year data set is maybe a better way to go. Other methods are exponential smoothing, where we can assign weights to, so more recent cases will get a heavier weight than older cases. So that's kind of the next step, moving averages and smoothing. And then we have, as Jennifer was mentioning, our partners at SINFI contracted a few biostatistics students to look at some other techniques such as cumulative sum and Poisson regression. So that's kind of the next phase as we go. Now, some of the rules that I showed are, these are things that we're looking for. We expect them. We also want to go the other way and develop algorithms to find things that we're not anticipating. So that's a little bit down the road. So we're just going kind of from the simple techniques and building up to more complicated techniques as we understand the signals that are coming from e-CHIRPP.
Well, it's Bill again. It looks like that's the end of our questions. And I wonder if you wanted to share any last thoughts amongst the presenters.
Sure. Hi, it's Jennifer. Again, I just want to thank everyone for your interest. You know, this has been a really very rewarding and exciting initiative for all of us to work on, and feels like we're paving the way for something really unique, and couldn't have done it without all of our colleagues here, coders and analysts, and of course the work of Canadian Network for Public Health Intelligence. And yeah, again, just thanks everyone for your interest, and our contact information is also on the last slide, so feel free to flip us an email if you have any other questions. Thanks.
Yeah, I was just going to say the same thing, just if there's a specific slide or a topic that people are interested in from the slide set, you can just shoot us an email, and we do have more information on those areas.
In addition, through the Simplified Network, we're trying to maybe organize a discussion panel or sharing of experiences and alerts. So we're moving forward on that for this fiscal year in the coming months. So perhaps people that are interested in finding more about the injury syndromics or alerts that we're developing, please let us know, and you're free to participate in our discussion.
Well, thanks very much to Jennifer, Stephen, and Wendy for your great presentations, and Janini for your help with moderating the Q&A. And it's been really a fascinating presentation, and learning about this e-CHIRPP and the Injury Syndromics seems like it's a pretty powerful real-time tracking and reporting tool. So lots of potential to build on that, and hopefully we'll be able to bring you back and have another update webinar on some of those next steps that you discussed. It'd be great to work together again on that. Well, thanks very much, everyone. Hopefully it's been a valuable webinar for those on the line, and hopefully you'll have a great day.